Hello and welcome back. So, continuing our discussion about the pediatric emergency medicine, in this video we will talk about the retropharyngeal abscess and the lateral pharyngeal abscess. So, the retropharyngeal abscess is a collection of pus located in the prevertebral space behind the pharynx, which is also referred to as the retropharyngeal space, located in the posterior aspect of the pharynx, right here on this picture. And the lateral pharyngeal abscess is located in the lateral part of the pharynx. Now, both of these can lead to life-threatening complications such as airway obstruction or sepsis, so it has to be diagnosed and treated carefully. Now, these abscesses result from infections that are most often polymicrobial, means more than one type of pathogens are involved, and the usual pathogens include group A streptococci and Staphylococcus aureus and oropharyngeal anaerobic bacteria. Now, there is increased incidence with methicillin-resistant strains of Staphylococcus aureus, and other pathogens can include Haemophilus influenza, Klebsiella, and Mycobacterium avium. Now let's talk about the pathophysiology. So the retropharyngeal and the lateral pharyngeal lymph nodes that drain the mucosal surfaces of the upper airway and the esophagus are located in the neck within the retropharyngeal and the lateral pharyngeal spaces, and those are shown here in this picture. And the retropharyngeal space is located between the pharynx and the cervical vertebrae and extending down into the superior mediastinum. So the retropharyngeal space is located between the posterior pharynx and the cervical vertebrae, like you can see here, and it is extending down into the superior mediastinum, while the lateral pharyngeal space is bounded by the pharynx medially, the carotid sheath posteriorly, and the muscles of the styloid process laterally. So we have lymph nodes within these spaces mentioned already, and those lymph nodes communicate with each other, and when there is an upper respiratory tract infection, it will infect the lymph nodes and the infection will spread from one node to the other ones, and this would lead to suppurative adenitis and lymph abscess. And infection of these lymph nodes usually occur as a result of extension from a localized infection of the oropharynx. Again, it would be most likely an upper respiratory tract infection causing the spread, and the retropharyngeal abscess can also result from a penetrating trauma to the oropharynx, or from dental infections, or from vertebral osteomyelitis. Now let's talk about the epidemiology. So the retropharyngeal abscess occur most commonly in children younger than 4 years of age, because the retropharyngeal nodes involute after age 5. This means that infection of the retropharyngeal space cannot be transmitted by the lymph nodes anymore. And also, infection in older children and adults is much less common because there is no lymph nodes to transmit the infection. So infection has to come by trauma or dental infection or by the vertebral osteomyelitis. Now, abscess formation occur most commonly in winter and early spring, and males are affected more than females, and approximately 2/3 of patients have a history of recent ear, nose, or throat infection. Now let's talk about the clinical features. So a patient with retropharyngeal abscess classically present with fever, irritability, drooling of saliva. This is because the patient might be tachypneic, means they are breathing fast, so they don't have the time to swallow their saliva because they are breathing fast, so their saliva drools. Also, they may have dysphagia and may also have inspiratory stridor, and that is because the retropharyngeal abscess will squeeze on the airway, leading to narrowing of the airway and the production of the stridor sound. Now, patients may hold their neck in unusual position with torticollis And this is when the patient is holding their neck in extension and either deviating to the right or the left, hyperextension, stiffness, or they may refuse to move their neck. Now, the verbal child might complain of sore throat and neck pain, and other signs can include muffled voice and respiratory distress, means the patient will be tachypnic. They are sitting in a tripod position and they are using their accessory muscles of breathing, and they may also have retractions, intercostal retractions or subcostal retractions, or even they may have obstructive sleep apnea. Now, physical examination can reveal bulging of the posterior pharyngeal wall, and this is present in less than 50% of infants with retropharyngeal abscess. So when you examine their mouth, you would see the bulging in the posterior aspect of the pharynx, and when you examine their lymph nodes, you might find out about their cervical lymphadenopathy, which may also be present. On the other hand, lateral pharyngeal abscess, commonly present with fever, dysphagia, and a prominent bulge on the lateral pharyngeal wall, sometimes with medial displacement of the tonsil. Now let's talk about the diagnosis. So the physical examination of the pharynx may show a retropharyngeal mass, and although palpation commonly will demonstrate fluctuance, which is very indicative of abscess formation, this could lead to rupture of the abscess and subsequent aspiration pneumonia. That is why we don't palpate the bulge, and we use the radiological investigations to confirm the diagnosis. So the lateral neck radiographs performed during inspiration with the neck extended may show increased width or an air fluid level in the retropharyngeal space, and the diagnosis is suggested when the retropharyngeal space at the C2-C3 level is more than 1/3 of the vertebral body width, or at C4 downward is more than the full width of the vertebral body. So as you can see in this picture here, we have swelling of the retropharyngeal space here, and here we have the vertebral body of the C2, and you can clearly see that this space here is larger than 1/3 of the vertebral body of the C2, means the retropharyngeal space is swollen and there may be an abscess within. Now, deep neck infections can be accurately identified and localized with CT scans, but CT accurately identifies abscess formation in only 63% of patients. And CT with contrast medium enhancement can reveal central lucency, ring enhancement, or scalloping of the walls of the lymph nodes and help differentiate abscess from cellulitis. Like you can see in this picture here, we have multiple abscesses formed within the retropharyngeal space. Now, scalloping of the abscess wall is thought to be a late finding and predict abscess formation. Scalloping means when the abscess wall become like this, and incision and drainage and culture of an abscessed node provides the definitive diagnosis. Now let's talk about the differential diagnosis. So the differential here include acute epiglottitis and foreign body aspiration. Those are very dangerous and they should be taken into account. Now, in the young child with limited neck mobility, meningitis must also be considered, and other possibilities include lymphoma, hematoma, and vertebral osteomyelitis. Now, to differentiate with acute epiglottitis, this has to be done radiologically or using the direct laryngoscope in the respiratory care unit. And to differentiate from foreign body aspiration, examination using a stethoscope might reveal a unilateral wheeze suspicious of foreign body aspiration, or it also can be differentiated radiologically using PA chest x-rays. Now let's talk about the treatment. So immediate airway stabilization is the first priority. You intubate unstable patients before performing CT scan. And treatment include intravenous antibiotics with or without surgical drainage, and antibiotic choice is controversial because most retropharyngeal abscesses contain mixed flora, and a third-generation cephalosporin combined with ampicillin, sulbactam, or clindamycin to provide anaerobic coverage is effective, and the increasing prevalence of methicillin-resistant Staphylococcus aureus can influence the empiric antibiotic therapy. For example, vancomycin can be added, and studies show that more than 50% of children with retropharyngeal abscess or lateral pharyngeal abscess as identified by CT scan can be successfully treated without surgical drainage, and the older the child, the more likely it is that antimicrobial treatment alone will be successful. Now, surgical drainage is necessary in the patient with respiratory distress or failure to improve with intravenous antibiotic treatment, and consider adjunctive treatment with parenteral steroids, example dexamethasone 0.15 to 0.6 mg per kilogram per dose to a maximum of 10 mg to reduce inflammation and edema. And the optimal duration of treatment is unknown, and IV antibiotics are given until the patient has begun to improve, and it is followed by a course of oral antibiotics. Finally, let's talk about the complications. So complications of retropharyngeal or lateral pharyngeal abscess include significant upper airway obstruction and rupture leading to aspiration pneumonia and extension to the mediastinum. Now, thrombophlebitis of the internal jugular vein and erosion of the carotid artery sheath can also occur. And another complication is infection of the parapharyngeal space, which is Lemierre disease, and this infection will extend from the oropharynx to cause septic thrombophlebitis of the internal jugular vein and embolic abscesses in the lungs. Now, the cause of the infection of the parapharyngeal space is by the Fusobacterium necrophorium, which is an anaerobic bacterial constituent of the oropharyngeal flora. Now, the typical presentation of the Lemierre disease is that of previously healthy adolescent or young adult with a history of recent pharyngitis who become acutely ill with fever, hypoxia, tachypnea, and respiratory distress. And chest radiography demonstrates multiple cavitary nodules, often bilateral and often accompanied by pleural effusion, and blood cultures may be positive. Treatment of Lemierre disease involve prolonged intravenous antibiotic therapy with penicillin or cefoxitin, and surgical drainage of extrapulmonary metastatic abscesses may be necessary. And with that, we reach the end of this video. Thank you guys for watching. Please give us a like, comment your ideas and questions, and subscribe. And please consider joining the channel using the link in the description of this video or by hitting the join button near the subscribe button down.